Sir, we are live now.
So good evening. We are going to start the program for the primer for the DNB practical exam. We call it as Ask Me Osce. Well, this is not only about the OSCE, it is about the entire practical examination that you're going to face. I think most of the DNB students across the country must have finished their theory now, are ready to take their practicals on 27. And I hope this will also probably help the next batch of students who are going to probably take this, go through the same ordeal in the coming months. So let's start straight away with the idea how to actually face this practical exam. You all know by now that you have 300 marks, but of 100 marks are allocated to OSCE, which is examiner independent. You have around 20 questions of 5 marks each, which are basically clinically oriented, but sometimes they can be a pure theory question also. So you have this questions which are put up, which are probably live streamed from the command center of the national board, and all of you will be facing the same questions at the same time. And this the examiners have no say. So most of these questions earlier they were little easy actually, but later now we are finding it to be little tough and from varied sources, and some of them are very difficult to comprehend in the time allotted. But I can definitely assure you that around 75% of the questions of the marks can be got. Like almost you can get most questions, and the best part is they're all basically broken down into the marks. Like you have 1 mark, 2 marks, it's already located. So even if you don't know some part of the sub question also, you still get marks. It is not all or none. So you can always know something. And even the questions will be basically some of them you can actually guess by. So you can see the screen, Navneet. Hello?
Yes, sir. Visible. Very clear.
Okay.
Yeah.
So I'm going to give you some idea. We have planning to cover around 50 OSCEs, the representative OSCEs. Of course, OSCE can come from any part of the ophthalmology, and people who set the OSCEs want to really include most of the things from ophthalmology, even the recent advances also, even the recent studies also. So it's very difficult to actually, answer all the 100% of the questions correctly, but you can definitely attempt all the questions. You can probably answer most of the sub questions also. So definitely you can score little extra marks in ASCII so that you can make it up for the rest of the practicals. Another 100 marks is basically for 2 cases. So normally we are also a center for the practical exams in DNB. So whatever we go through, I think every center, every practical center has the same trials and tribulations. So let me kind of share you some secrets. So whatever cases that we actually get for the practical exam are basically limited by the availability. So we cannot give very hot cases, a very eyes with a lot of pain or inflammation, and cold cases normally come. And since there are only 2 cases, we don't have a separate entity as like fundus case in some of the universities. Some of the examiners may prefer to keep the second case as a retina case, usually a patient with some retina findings. So you will normally have one retina case and one non-retina case as 50 marks each. So in the non-retina case, normally a corneal ulcer is very easy to find in a hospital. Mostly fungal ulcers which are there keep coming to the OPD, maybe partially healing, maybe a fresh case. Then it's very easy to keep a keratoconus because keratoconus findings never go away. So in the cornea, you can have a keratoconus. And post-keratoplasty is a very common case that you can always think of. So you should be ready for that. In glaucoma, any patient which comes to the OPD can be a glaucoma case. They always have disc findings. So they always have some of them will be on treatment with normal IOPs. You can always keep a case of glaucoma. Some secondary glaucomas like neovascular glaucoma or eye syndromes or PXF glaucoma can also be kept. You may rarely find just a case of cataract, like a hypermature cataract or some subluxated cataract or a subluxated lens can be there in those situations. And ptosis, definitely either an aponeurotic ptosis or we can have a congenital ptosis. These two can be there. It can be kept in the exam. Very rare to have a proptosis. Thyroid eye disease is another very important thing which will be definitely kept in the exam. And in retina, you have those standard diabetic retinopathy, retinitis pigmentosa, retinal detachment, AMD, macular hole, and CR vivo and BR vivo. So these are the common things that you can actually find. So let us start away with OSCE. So I'm just trying to kind of give you some idea about the uh, OSCE so that you can get an idea. Like, for example, this will be normally the photograph and the questions will be in the same slide. So it will not be two separate slides mostly. So they'll give a picture like this and there'll be four questions. So the first question is name the condition. Obviously, you know, it is a choroidal coloboma. So it's a choroidal coloboma. So you'll get 1 mark straight away. What layer is absent in this abnormal area? So normally here the choroid is absent. You have sclera and you have atrophic retina. You have no choroid because there is no choroid, which is a nutritive layer. The retina becomes atrophic. So the answer for the second question is choroid. Name two complications of this condition. Obviously, when you have this at the edge of the coloboma, you have uh, basically the chances of a retinal hole, so retinal detachment. So retinal break formation at the retinal hole at the edge of the coloboma. And even you may have a choroidal neovascular membrane, which can lead to a hemorrhage. So these are the two complications. So since there are two, I've asked for two complications, it will be 2 marks. And what is the prophylactic treatment? The barrage laser, basically at the edge of the coloboma, so that the retinal detachment will not progress into the macula. So, or they can even ask a question like, what will be the vision in this patient? Will the vision be normal or abnormal? Since macula is not involved, okay. So you can always say the vision can be normal if there is no other problem. Can the vision be 6/6 in this patient? Could be the answer. So they can think of any four questions or even three questions. So depending upon this, so you can just think there is no any logic to set up the questions. So let's have the second question. They will put up a photograph like this. Name the condition. Obviously, it's a band-shaped keratopathy. It can be also in some patients called calcific keratopathy or calcific band keratopathy. So any name should be okay. But most commonly, what is commonly accepted, write that name, either BSK or band-shaped keratopathy. No, don't write short forms. No acronyms to be used. At which layer of cornea this opacity is present? This is normally a calcium deposits in the Bowman's layer. It can also present, go to the anterior stroma, but they expect you to at least write Bowman's layer. So you can write Bowman's layer, Bowman's membrane. Name two conditions in which this can be found. So there are plethora of conditions. So at least write the most common ones. Even if you write the uncommon ones also is fine. But most likely it is associated with chronic uveitis, especially with juvenile idiopathic arthritis. So this is very common. Any even a blind eye like phthisis bulbi, herpetic keratouveitis, chronic inflammations, severe dry eye. So all these conditions, even pilocarpine usage, there are some drugs like pilocarpine can cause this. So you name two most common ones so that you can get 2 marks. Treatment is, of course, chelation with EDTA. You can scrape the epithelium. You can write, since I've written mention the treatment, you can write a sentence like removal of the debride the epithelium over the BSK and apply, okay, EDTA solution to remove the calcium deposits or chelating agent like a EDTA. Should be fine. So identify the device. So this can be a little tricky. So what the examiner wants that this should be called as a telescope. So this is a low vision aid. You can get a clue that this is a low vision aid by the second question because they've written definition of low vision. So obviously, if you write it's a low vision aid, whether they give full marks or not, again is a point of contention. They may examiner may have an idea that this is could be called as a telescope low vision aid or telescope would be the answer. So here there is some kind of a subjectivity. Examiner may give 1 mark for writing it as low vision aids, or they may insist on telescope. There is always a problem with this. So definition of low vision. Obviously, the WHO definition is any patient in the better eye, the best corrected vision is between 618 to 3 by 60. And the visual fields from 40 degrees to 10 degrees, this is called low vision as per the WHO. So this is expected for 1 mark. Then they have written something else like how do you manage the convergence insufficiency while using a high plus lens? If you use a high plus lens, there is no accommodation that is happening. So there is be less convergence or no convergence. So patient will have convergence insufficiency whenever they are using a binocular instrument. So how do you manage that? There are 2 marks. So that means you are supposed to, you are expected to write two things. One is by decentering of lenses. Second, by adding a base in prisms. So this is what the examiner has in mind. So you should be actually able to get that right. Okay, if you write one, they will not give the other mark. So it has to be both decentration as well as base in prisms. Then what is the simplest LVA for near? This you have to read the examiner's mind or the person who has set the OSCE. He probably means or he or she probably means that it should be a high powered convex lens. Okay, high plus lens is the simplest LVA for near. Okay, they'll put this chart. So chart is this is Amsler's grid. Everybody knows 1 mark is easy. At what distance? 33 centimeters with near correction. Okay, that is additional. How many small squares are present? Okay, in this, and what is the so it is basically eight. So at what angle each of them subtend? So it's 1 degree basically at 33 centimeters. So mention one use of this. Obviously, this is to track the AMD, age-related macular degeneration for the activity. So, or to identify the development of wet AMD or neovascular AMD. So you can write anything, but you should basically understand what they actually want to ask. So these goggles, so you may write it as red-green goggles, but they are named as Armstrong goggles. So what is the correct answer? Here there is a problem. So I just want to basically, I'm using this OSCEs to make you understand that there's a lot of subjectivity in the OSCEs. Because I may be expecting you to write Armstrong goggles, but even the red-green glasses should also actually, and the red is always in front of the right eye. That is the convention. You should know this. Even that could be the question. Where should be the right? Because on that basis only we decide the outcome of this. Can this be used to test binocularity? Can be a question. Yes. So red-green glasses are used, or this is a Worth 4 dot test can be used for test binocularity for distance as well as for near. Can a person with red-green color blindness perform the test? No. But a red-green blindness person can perform a duochrome test, not a Worth 4 dot test. You should know this. If two red lights are seen on the left side and three on the green, three green on the right side. So normally the right eye will have the red light. If it is on to the left side, that means it has crossed to the other side. So it is a crossed diplopia. So if you have a cross diplopia, it is an exotropia, okay, or an exophoria. Both can be the answers. Because this is a dissociation test, this red-green glass dissociate. So this could be the answer. So like they can put a clinical photograph like this. This is a typical bite out spot, that foamy conjunctival lesion. What are the consequences if left untreated? There are 2 marks. So they expect you to write two complications. One, you can write it as, this is a conjunctival xerosis, obviously. So you can write as keratomalacia, corneal perforation. Okay, this could be the answers. Or conjunctival xerosis can also be an answer. Give prophylactic treatment. We give the prophylactic treatment regimen with dosage for prevention of the above condition in children above 1 year. They've asked for 2 marks, so probably they want you to write the this one. So basically, for about 2 years, you basically 2 marks means you have to write the frequency of the administration as well as the dose. So 2 lakh international units of vitamin A given orally once in 6 months. So that is the prophylaxis. So that's why there are 2 marks for this. So they can put a thing like this. So what's your diagnosis? It is microspirophagia of any etiology. There are also two syndromes associated with this: Marfan syndrome, homocystinuria, Weil-Marchesani syndrome, Alport syndrome, Lowy syndrome. It can be anything, but write the most common, like Marfan's definitely. What are the refractive implication? Because the lens is becoming more spherical, you have a myopia. So you have a lenticular myopia with this condition. So you can write myopia should be good enough. One complication, they've asked for one complication. It can be the lens getting, dislocated into the anterior chamber, or it can be a pupillary block glaucoma. It can be a dislocation or a subluxation of the lens can be one of the complications. So this, they can put a condition like this. See here, the question is, what is the most likely diagnosis? So the examiner has CPEO in mind, chronic progressive external ophthalmoplegia, probably because he or she has this as a stock image from her, image gallery. But you may be completely unaware of this. So the answer for this, the key may be CPEO. So if you are not really, just go down the other questions, you will come to know. They've asked for a genetic basis. They've asked for two systemic abnormality. So obviously, it is not some bilateral aponeurotic ptosis or something like that. So can you attempt? And they've also given a clue that this patient has total restriction of ocular motility. It's severe ptosis. Probably you should. It must be a simple guess that it is CPUO. Can you attempt ptosis surgery if the patient desires so? No, because there'll be no elevation possible. Wells is almost absent. So no ptosis surgery should be performed. Or you can say, they can also say, what could be the complication if the patient undergoes ptosis surgery? That could be one of the questions. That patient will have severe exposure keratopathy. What is the genetic basis? This is basically a mutation in the mitochondrial DNA. And name two systemic abnormalities associated with this condition. So normally in Kearns-Sayre syndrome, you can have cardiac conduction abnormalities. You can have pigmentary retinopathy. These are the two associated situations. So you can have. So these are some of the things like, then of course strabismus, again a squint is always a problem. Strabismus, since the child completely, regains her binocularity with glasses, it should be called as, this is basically a refractive accommodative esotropia. What is the refraction usually? It is hypermetropia. Can surgery replace glasses? You should say no. The answer is only no. Don't try to explain. Esotropia entities. Like infantile esotropia is the most common non-accommodative esotropia. Then you can write anything, cyclic esotropia, esotropia in myopia, okay, microtropia. There are many non-accommodative esotropia entities. There are plenty of them. Convergent sexes, divergent insufficiency. All those are non-accommodative esotropia entities. You can write any one of them, but at least write the most common one. The infantile esotropia is the most common non-accommodative esotropia. Of course, this is a thyroid eye disease, most likely causes a dysthyroid orbitopathy. You can write anything, thyroid-related orbitopathy, thyroid eye disease, anything is fine. Two lid abnormalities, lid lag and lag of thalmus, write the most common ones. Two sight-threatening complications, compressive optic neuropathy and corneal exposure and corneal blindness. Okay, so these are the basically the some of the OSCEs I wanted to tell how they can actually be twisted, how they can, you have to read the examiner's mind many a times to get the answer right. If you really can't get it, go down the other questions and at least make a guess to fill it, because there is no negative marking. You can always try writing all the answers. Okay, and obviously in one of the table vivas. So another 100 marks, you are ideally supposed to have four table vivas. One of the table vivas is supposed to have refraction as well as research methodology, where they're going to ask you about your thesis and the details of the thesis, since you have already completed the research work. And refraction, they will just give you a retinoscopy cross with this finding. So you should please ask the examiner to give the working distance and the cycloplegia used. So in this, it is the, so most of the uh, students get into confusion and get into trouble, and any mistake in refraction is not taken very well. There is no mercy by most examiners if the basic refraction goes wrong. So I'm trying to tell you, you may probably not know some latest study or some very complicated retina condition, okay, or some very new procedure, but please do not make a mistake of doing the diffraction wrongly. So let me reiterate this once again. If the working distance is 2/3 meter, you are going to subtract 1.5 diopters, right? If the working distance is 1 meter, you're going to subtract 1 diopter. Got it? It's a dry refraction, so you're not subtracting for cycloplegia. always subtract from only one meridian and put it as a spear. Don't subtract from both the meridia. The spear works all 360 degrees, so subtract from only one meridian. So 1.5 should be subtracted from plus 2 for information. Then it becomes plus 0.5 diopter spear. Then the second part, the cylinder is the difference between the two meridia. So from plus 2 to plus 3. So you have already taken plus 2 as the meridian. Now to go to the second meridian, from plus 2 you have to go plus 1 diopter more. That becomes your cylinder. So put plus 1 as the cylinder. Since it is at the horizontal level, you have to put vertical, I mean the 90-degree opposite is 90 degrees. So your answer will be plus 0.5 diopter spear plus 1 diopter cylinder at 90 degrees. So you have to write this, no mistakes done. And please always mention the type of astigmatism. This will be a compound hypermetropic astigmatism with the rule astigmatism. So all astigmatism, all cylinders with minus cylinder at 180 plus cylinder 90. Both of them are with the rule. So remember one thing, so you know the opposite. Minus cylinder 180 plus cylinder 90 is with the rule, and both plus is a compound hypermetropic astigmatism. Let me give you one more example before I leave you. So here it is plus 2 vertical, minus 3 horizontal. Ask for working distance as well as cycloplegia. This is a 1 meter working distance and dry refraction. So you have to subtract 1 diopter. So let us start. So you take plus 2 as 1 meridian, plus 2 minus 1. So plus 1 diopter spear. Then for the cylinder, from plus 2 to go to minus 3, you have to travel 5 units along the number line towards the negative side. So from plus 2 to minus 3, it is minus 5 at 90 degrees. So it will be plus 1 diopter spear, minus 5 at 90 degrees. And this will be against the rule, but a mixed astigmatism. So this is against rule because it's a minus cylinder 180 is with the rule, minus cylinder 90 is against the rule. And the plus and minus are there. Always a mixed astigmatism, the cylinder value is more than the spear. Okay. And they may ask you to transpose this. So add plus 1 and minus 5, it will become minus 4 as the spear. Change the sign of the cylinder. So make it as, this will be a plus 5 diopter. So minus 4 spear, plus 5 cylinder, 180 will be the transposition. So this will be an against the rule, mixed astigmatism. So with this, we kind of get some kind of an idea about how OSCEs should be tackled. So now I request Dr. Aniket Shastri, our consultant in the Department of Phaco-Refractive and Cornea Department. So he will be covering some of the anterior segment OSCEs. That is the most likely one and the representative ones. Then followed by, we'll have some OSCEs from retina. So over to Dr. Aniket Shastri for his OSCEs from the anterior segment.
Yes, sir. Good evening, everyone. Able to see my screen?
Yes.
Yeah. So I'll just sharing around some 15 OSCEs related to cornea and refractive surgery. So this is our first OSCE. Now here, if you see that the question is that you are presented with the patient complaining of pain, photophobia, reduced vision for 1 week. The clue here is that the patient has a history of trauma with an organic matter. And then the scrapings were sent for microbiological examinations. We are all well versed with our clinical features actually. Microbiological examination is something that we usually don't concentrate on. So that is the reason why I've included this. So this is a typical case of fungal corneal ulcer. And the first question here is we need to identify what is the microbiological procedure that's been performed here and what is its interpretation. So we all know that for once we take the scrapings, the investigation that is for fungal keratitis is a KOH wet mount. So interpretation of a microbiological procedure here is a KOH wet mount. And the procedure that what is the interpretation? Like, how do you read this slide or go through this slide? These are all refractile hyphae. Refractile hyphae with a septate or aseptate, branching or a non-branching. These are all filamentous fungi. So basically what you're seeing here is a filamentous fungi. These are all the refractile hyphae seen on a KOH wet mount. So next question is, what is the recommended culture media for isolation? So we all know that for fungus, we use a Sabourates dextrose agar. But one thing to add, always never forget to complete the answer here is Sabourates dextrose agar without cycloheximide, because the other places are, they use cycloheximide to stop the commensals, but for us, our own Aspergillus and Fusarium are the main organisms that are causing it. So we want it without cycloheximide. And on the culture growth, what is a key characteristic feature is another next question. So we have fluffy colonies, white cottony colonies, fluffy colonies in Fusarium, or we have granular and dark green colonies usually seen in Aspergillus. Now, what is the drug of choice when you're managing such cases? Now, according to the mud trial is something that we can ask, they can ask as a parallel question here. So it said that natamycin is superior to voriconazole when it comes to treating filamentous fungi. So that marks your 4. So try to concentrate on microbiological evaluation also, especially for fungal and bacterial keratitis. So we'll go to the next question now. This is a medical student who has been wearing glasses, comes with blurring of vision with no improvement with glasses. So this is the clinical picture. So we are able to see quite classical. Now, what is your diagnosis here? Diagnosis, try to put it always as corneal ectasia, probably keratoconus. So always try to use the word corneal ectasia whenever you're describing any kind of lesions, be it keratoconus or pellucid marginal or post-LASIK ectasia. Use the word corneal ectasia. This is something, the 4 clinical features of this condition. These are things which we all know when we have been presenting cases or going through it. So one of the clinical features is, of course, the ectasia is associated with thinning of the cornea. Then you have all the famous signs like the Munson's sign, the Rizzuti sign, the oil droplet sign on distant direct ophthalmoscopy, scissoring reflex on retinoscopy. Then you have the Vogt's striae. So these are the many clinical features. You can write any 4. Name 1 ocular and systemic associations. So one of the commonest ocular associations that are associated, with keratoconus is your vernal keratoconjunctivitis. You have the VKC, or sometimes even your retinitis pigmentosa. Systemic associations, we all know Down syndrome. Try to remember at least 2, so that if in case they ask, right, just name 2 systemic instead of 1 ocular, 1 systemic. You should be able to answer that. We have got the Down syndrome, we have Leber's amaurosis, we have the tapetoretinal degeneration, we have atopy, multiple conditions, we have connective tissue disorders like the Hallerdan loss. So those are multiple systemic associations. And now the last question here is, how do you manage this case? We have asked 2 surgical management options. I have put other than C3R because C3R is something, corneal collagen cross-linking with riboflavin is something which everyone knows nowadays. So what else can be done is, you can use an intracorneal ring segments. You can do anterior lamellar keratoplasties, penetrating keratoplasties, and nowadays we are even trying Bowman's layer transplants also. So these are some of the surgical managements other than corneal collagen cross-linking. We'll go to the next. So this is something which we all would have seen during our clinical postings. So what does this picture depict? This is the classical case of herpes zoster ophthalmicus, right? And the next question that's been asked is, what are the 2 risk factors that are associated with the same? Zoster ophthalmicus usually occurs in case in an adult is usually after the age of 60, because the immune system has, the antibodies have come down after our first shot of either the vaccine or the chickenpox that we got. So it's an immunocompromised individual. It's either an old age, which is very common, or if it occurs in young people, then it either has to be an HIV infected person or a person who's undergone an organ transplant who is on immunosuppression. So these are some of the risk factors that are associated with HZO. Then this is another thing that is important. Which sign is clinically predictive for whether or not IV involvement occurs in this disease? We all know that it is Hutchinson's sign. That is involvement of the nasociliary nerve, that is the tip and the ala of the nose. The nasociliary nerve gives an offshoot part of the first branch of the trigeminal nerve that supplies the anterior segment of the cornea. Therefore, if your tip of the nose and ala is involved, which is the nasociliary branch, then there is a very good chance that your cornea may also be involved. So how do you treat this condition compared to a simplex, herpes simplex, which is usually a topical disease, a topical treatment most of the time? That when it comes to herpes zoster ophthalmicus, it is always an oral treatment. So we use an oral acyclovir, 800 milligrams, 5 times a day. Try to always completely write the treatment. Just don't write oral acyclovir. 800 mg 5 times a day for at least 7 days. Nowadays, we use oral valacyclovir 1 gram BD or TDS for a period of 7 days. So next, we go to charts. Some of the interesting charts here. This is a very common chart. Now, what is the investigation that's been performed here? Once you see an elevation map, always try to remember that this is a corneal tomography that will give you more marks. Corneal topography also can be written. It's a common word, but tomography is a 3D image that gives elevation-based data. So what is the principle behind this? These are all elevation-based devices. So this is a pentacam. So the principle behind this is Scheimpflug principle. Now name two commercially available such devices. You can always, famous is the pentacam. The other two are the Sirius or the Galilei. These are all Scheimpflug images. You have a scanning slit images, which also gives an elevation map to some extent. That is an OBSCAN. Okay, now here the next question is something which I think everyone should be knowing. These are the 4 common maps that are used for the analysis. These are the 4 maps that are there in front of you. They're already named actually. So you have the sagittal power map, then you have the pachymetry map, and then you have the anterior and the posterior elevation map. So what are the indications for this investigation? When does a patient has to undergo this? Most common is, of course, your refractive surgery workup before your any kind of refractive workup. Then when you want to diagnose your ectatic corneal disorders, these are the 2 main indications. So at least try to remember these 2 indications. There are multiple other indications like toric, suture adjustment in PK, intact, phakic IOL. So at least the 2, like refractive surgery workup and diagnosis of corneal ectatic disorders like keratoconus. So there can be questions regarding some procedures also. So what is the procedure that's being performed here? May not be commonly seen by many people, but most of our textbooks do have this picture. So the procedure that's been performed here is, of course, your corneal collagen cross-linking with riboflavin. And what is the most common indication? And we do it for a progressive keratoconus. Try to remember the word progressive. Okay. So what is the name of that standard protocol that we usually use? We use the Dresden's protocol, which you take out the epithelium, you add a riboflavin for 30 minutes, and then you expose the eye to the ultraviolet radiations. Try to remember the concentration of riboflavin, or what is the power and the energy that is utilized in the ultraviolet radiations. Also, I've just put this answer as name any 2 alternative protocols you need to know other than the Dresden. What else can be there? There is something called as an accelerated protocol, C3R, that is also commonly performed. We have an epithelial on protocol. Then there is something as the Cretan and the Athens protocol, where in one Cretan we try to do a topo-guided PRK followed by a C3R. Athens protocol, we use a PTK model to use a PTK laser to take out the epithelium followed by the routine protocols, Dresden protocol. What are the 2 complications specific for this procedure? So this procedure is something you need to name for this procedure, which is something that usually is seen because we take out the epithelium. There is a very good chance of having an infectious keratitis. And then another complication that is associated with this is a corneal haze, because the eye is exposed to that long duration of ultraviolet radiations and delayed epithelial healing. So this is something that is for C3R. Complications for C3R. Now this is another surgery that's been seen here. This is an animation. So what is the surgery that is being done here? Yes, we all know it as smile or a clear, but the technical term try to use is a refractive lenticule extraction, where an example is probably a smile or a clear. Just try to ask what is the laser platform is required. We usually require a femtosecond laser to perform any kind of refractive lenticule extraction. Also try to remember what other corneal procedures are there. We all know the famous LASIK. That's why I didn't involve LASIK. I tried to put in a refractive lenticule extraction. So name the other corneal refractive procedures which we know. That is, one is LASIK, and photorefractive keratectomy or the PRK. And just to for your knowledge, I have put in a word as to which laser platform is used there. Here we use an excimer laser. It's an excited dimer. This is a gaseous laser, that is a femtosecond laser there. What are two absolute contraindications for any of the corneal refractive procedures? One absolute contraindication is, of course, any kind of ectasia is a contraindication. You're not supposed to touch the cornea. Any residual stromal thickness, if the cornea is thin and the residual stromal bed is going less than 250 microns, and that is a contraindication for corneal procedures. A case of severe dry eyes. So I've given you 3 reasons, so at least try to remember 2. We come back to our clinical picture. Now this is a 40-year-old lady that comes with 3-day history of eye discomfort. So how do you describe this lesion? Of course, we all know that it's a branched dendritic lesion, but the 2 characteristic features of the dendrite is something which should not be forgotten. The 2 pathognomonic features of a dendrite is a reticular band of punctate epithelial microdestruction. This reticular band that is there surrounding the dendrite is the one that is pathognomonic, and terminal end bulbs. So these are branched dendritic lesions with terminal end bulbs and reticular band of punctate epithelial microdestruction. That is how you try to describe a dendrite. So now what is your diagnosis? Of course, it's an HSV, epithelial keratitis. HSV. In that you have the dendritic ulcer. Okay, so what is the mainstay that is there in the management? Mainstay is our acyclovir eye ointment 5 times a day to be given for at least 14 days. Fine. What is the role and consequence of using steroids? Steroids are absolutely contraindicated in your epithelial keratitis. Steroids are indicated in stromal keratitis. So that is, there should be no confusion in this. There is absolutely no role of steroids when it comes to a dendrite or a geographical keratitis. In fact, use of steroid can progress this dendrite into a geographical ulcer. So if a geographical ulcer case comes to you directly on your first visit, then either steroid has been misused in this patient or there is a local immunodeficiency in this patient. We'll try to involve a slide on eye banking. Anything can be asked. Of course, what is the preservative medium that has been displayed here? So this is the MK medium, or also called as the Macquarrie-Kaufman medium. Okay. So what is the preservation time? That is, the preservation time as such is either it's a medium preservation, intermediate preservation, or it's a long preservation. Okay. So MK medium comes under a lesser preservation medium, where we have the preservation time is for only 3 to 4 days. Try to remember the contents of the medium. What are the contents of the medium? So you have the tissue culture 199, then you have dextran 40 there, and you have a gentamicin as an antibiotic, then you have a HEPES as a buffer, and of course the red color is because of the phenol red. Okay, now I have included the 4th question to complete the preservative mediums as to name one long intermediate duration and a long-term duration. Intermediate duration where you can store it for 14 days, where you have Optizol, Dexol, or a Kazol. Okay, a long-term duration is for months together, where you have an organ culture or a cryopreserved. So this completes most of your questions, even if it's a 5-mark question on your iBank storage. So this is something which I think hopefully everybody has seen. So what is the investigation that's been done here? This is endothelial picture from a corneal specular microscope. So this is a corneal specular microscopy has been done here. So when the quantitative data is given to you, the 4 quantitative parameters for the above investigation that going to describe the endothelial mapping, the 4 things that have to be that you are supposed to see in both clinically and from the exam point of view is, of course, your central corneal thickness, the CCT, the cell density CD, which is cells per millimeter square, then pleomorphism, that is the percentage of hexagonal cells that is given as 6A, and coefficient of variation CV, which is the polymegathism. So these are the 4 things: the CCT, cell density, 6A, which is telling you about the pleomorphism, and CV, that is giving you polymegathism. So what are the 2 indications for this investigation? We do this in case of suspected Fuchs endothelial dystrophy, and if you suspect any kind of endothelial dysfunction prior to an intraocular surgery. An uneventful surgery in another eye has given rise to endothelial decompensations. You want to do in this eye cataract surgery, you try to plan it with a specular microscopy. You can use it in a iridocorneal endothelial syndrome, that is the ICE syndrome. These are some of the indications for the investigation. So what should be the endothelial cell density in a donor tissue for optical keratoplasty? Remember, the endothelial cell density at different ages. What happens in infancy, in adulthood, what is the average? So here for an optical keratoplasty, for a donor tissue, they should have at least 200 to 2500 cells per millimeter square. When it goes below 800, that is when clinically you start having corneal edema. Corneal trifines and keratoplasty could also be one of the questions there. So what is this corneal trifine that's been shown here? So this is actually a suction trifine. It's been given a name as Hesburg-Baron suction trifine. So what is its use? Why do we use this suction trifines? Is for doing a partial trifination. We don't do a complete trifination. We do a partial trifination, especially in our lamellar surgeries. So what are the different types of lamellar keratoplasty? You need to know. One is, of course, DALK, D-I-L-K, deep anterior lamellar keratoplasty. You have Descemet stripping endothelial keratoplasty, which can be automated. Then it becomes Descemet stripping automated endothelial keratoplasty, and DMEC. So this is the order of the rejection also. DALK has got DALK, DSEC, and DMEC. So what is the Kodados line? Kodados line is famous, the linear accumulation of endothelial rejection cells. Rejection can also be an offshoot of any kind of keratoplastic questions. So it can ask about anything related to rejection. So Kodados line is a linear accumulation of endothelial rejection cells, typically seen in endothelial rejection, and it's a dangerous sign because that is going to give rise to endothelial dysfunction in the long run, even if the signs recover. So what is the initial management of any kind of graft rejection? Steroids, topical steroids, the first line of management. You can give oral steroids also, or if it is a severe endothelial rejection, you can give one shot of methylprednisolone as well, IV. Of course, with systemic, with topical cycloplegics and IOP lowering agents. So what is the investigation that's been done here in this clinical picture? So this is an anterior segment OCT that's been performed here. You can be given an anterior segment OCT that's been showing anything in there. There can be an intact segment in anterior segment OCT. There can be a DSEC graft in an anterior segment OCT. So here, what is that red arrow which you're able to see here, which is the procedure that's been performed? So here, that thing is a phakic IOL. Okay, so it is one of the lens-based refractive surgeries where in high myopes and in people not suitable for corneal procedures, we try to place a lens inside the eye. So this is a phakic IOL. Okay, so what is the most important preoperative parameter for a patient to be eligible for this procedure? You have an anterior chamber depth. So this anterior chamber depth should be more than 3 millimeters. There can be a question to describe what is actually an anterior chamber depth. It is from the endothelium till the anterior lens capsule. Okay, so that is the anterior chamber depth, and the distance between this phakic IOL and the crystalline lens is called as vault. So name any two complications that is specific for this procedure. For this procedure, phakic IOLs as such, they can cause anterior subcapsular cataract because of its proximity to the lens, and because they are shallowing your AC, they can also cause angle closure glaucomas. Coming to this procedure now, management of some of the ulcers, where what is the procedure that's been performed here? If you can see, this is a glue BCL. We have performed a glue BCL. So give one example of a tissue adhesive that is commonly used. This commonly used tissue adhesive in a glue BCL is cyanoacrylate. If you want to be more specific, it is N-butyl cyanoacrylate. What is the indication for this procedure? So indications are corneal perforations up to 2 to 3 millimeters. You can do a glue BCL, a descemetose seal to prevent further perforation, and corneal meds. So these are some of the indications. They may ask one or two. So in case to complete this question or complete this process, I have just put a question where what are the alternative procedures that can be performed if the tissue adhesive is not available with you? Tissue adhesive is not there. What else can you do? If it is a central perforation or a central descemetose seal, you can do a Tenonsplasty where you can get the tenons from the same eye and suture it there. You can, if it is a peripheral one, you can do a conjunctival hooding, or in cases where it's slightly more than 3 millimeters, 4 millimeters, you can do a patch graft as well. Now, what is this? So this is which implant can you see in this picture? This is a Boston keratoprosthesis 1 or a Boston K-Pro 1. Okay, Boston K-Pro 2 actually will come out through the lid. So this is on the cornea, the lids are intact. So this is Boston K-Pro 1. If the eye is closed and this optic comes out of the lid, then it becomes a Boston K-Pro 2. So what are the two specific indications for this condition? Anytime you want to put a K-Pro, it's always a bilaterally blind patient. One eye the patient is able to see, then the other eye you don't usually do a K-Pro. K-Pro is in case of bilateral cases of something like cicatricial corneal opacities like Steven-Johnson syndrome, ocular cicatricial pemphigoid, acid injury is bilateral, chemical injury is bilateral. A case of repeated graft, the other eye is not working. This has undergone repeated grafts, 3 grafts, 4 grafts, 5 grafts, then the only option left to use keratoprosthesis. The person has to be a bilaterally blind case. So give one specific complication for this implant, though you can always say retinal detachment, glaucoma, RD that can occur in any other PK as well. Specific for this is a retroprosthetic membrane. A membrane that comes behind this, a retroprosthetic membrane. Because the implant is in touch with the cornea, you can always have a corneal melt and extrusion of the implant. These are some of the specific complications. This is a non-bio implant. This is from PMMA material. So give one example of bio-integrated implant. You should always try to remember MOOKP, MOOKP, which is modified osteoodonto keratoprosthesis. Coming to the end, last couple. So 50-year-old lady comes with sudden onset pain, ocular irritation in both eyes. This is a clinical picture. So what is your diagnosis? Yes, this is a corneal dystrophy. You see a multiple flecks that are there in the center and in the mid-stroma. There are clear gaps in between. So what is this? This is a granular corneal dystrophy type 1, a classical one. Why I have included the second question is what is the gene responsible for this condition? It's a transformation growth factor beta 1. So why is it important? Because the latest IC3D classification of corneal dystrophies has given a separate classification of epithelial and stromal. It's an epithelial, Bowman's membrane is 1. Then you have epithelial stromal, which the whole group has TGF beta 1 mutation. That includes granular dystrophy type 1, lattice dystrophy, Thiel-Behnke, Reese-Buckler. So these are the dystrophies which are TGF beta 1. So they are completely grouped separately in our latest dystrophy classification. Another thing that is very fond by the examiners are what is the histopathological stain and the material deposited, especially for your stromal dystrophies. So in this case, we have the deposits as keratohyalin and we use the stain Masson's trichome. When it comes to, you also remember what happens in lattice and macular. In lattice, you have an amyloid deposit and we use Congo red stain for histopathology. When it comes to macular dystrophy, we have glycosaminoglycans and Alcian blue. So macular dystrophy as such doesn't belong to in the classification when it comes to TGF beta 1. It goes separately as stromal dystrophy. Okay. So what is the treatment for this condition? In the early cases, you can do phototherapeutic keratectomy or PTK. And in later stages, you can do a deep anterior lamellar keratoplasty. The cause for sudden onset pain and ocular irritation in this size in an early cases, it can cause recurrent corneal erosions. So it can cause a recurrent corneal erosion. That is the reason why this lady has sudden onset pain and ocular irritation. So coming to our last slide. So this is a 35-year-old male with severe pain, DOV, redness, watering, photophobia. Classical picture. This is a textbook picture. So what is the clinical sign here? This is a ring infiltrate. This is a characteristic ring infiltrate. There is a central dense stromal infiltrate. If you want to go more in detail, central dense stromal infiltrate with a characteristic ring infiltrate. So what is the provisional diagnosis? Probably suggestive of acanthamoeba keratitis. Next, what is the reason for such severe pain? The word that an examiner is looking for here is radial keratoneuritis. So what is actually a radial keratoneuritis? It is infiltration of the parasites along the corneal nerves. So infiltration of the parasites causes severe pain. That is radial keratoneuritis. So what is the culture medium used for inoculation of the organism? We try to use a non-nutrient agar with E. coli overlay. Each and every word of this culture media is important. It is a non-nutrient agar with E. coli overlay. So what are the topical medications specific for the organisms? The things which you have to remember are your propamide, chlorhexidine, bigonides. These are the three things that are specific for acanthamoeba. So I'll try to repeat: propamide 0.1%, which is Brolene. We have cycloheximide 0.02%, and PHMB, which is a bigonide, which is 0.02%. So hopefully this gives you the picture.
Thank you, Dr. Aniket. So that has given you some idea like how you can have from the anterior segment cornea refractive. So the whole ophthalmology is up for the examiner to set your OSCE. So just have some logical approach, and it will be very easy. At least if you follow this, you will be at least 70 to 80% of the OSCEs you will be able to clear, so that you can have some leeway for your cases. And about the Viva. See, even though sometimes we have 4 tables as prescribed by the national board, sometimes the 2 examiners can sit together and combine the 2 table vivas together. So you may have a lot of instruments, charts, drugs, the some kind of even photographs from their laptops, images can also be used actually to propel the viva. So Viva, there are few things before we go to Dr. Giriraj Vibhute for the retina OSCEs. Just a few things. You have to go through some simulation exercise. Please rehearse the whole way by which you answer the. So think of some common questions. How you are going to format the answer matters. Many a times, most of the students know the answer, but they fail to initiate the answer well in time. They take too much of time. They start with the most irrelevant part of the answer first. So always tell the most common thing first, most basic first. At the same time, format the answer, rehearse some of the common answers. For example, if you have a set of instruments, what instruments can be kept? Usually, you know most of them that we use in our routine practice. Calipers, Sinsky hook. Okay, don't, if they ask you to pick up an instrument where there is some discussion possible. Okay, don't pick up an instrument on which no discussion is possible. Don't pick up an artificial tears. Pick up a glaucoma drug. Don't pick up an artery forceps. Pick up a calipers or a Sinsky hook on which you can discuss. So try to have some mind game, and always don't use acronyms. No short forms. There are some short forms for drugs and diagnosis which is used in your own setup, but not elsewhere. So most examiners want you to, if you don't know the answer, no problem. You say, I'm not able to recollect at this moment. They will give another option, or they may give you a clue, or they may ask a totally a different question. Okay, so basically, brave heart, what saves you. So just be very, cool and collected. Don't have a very sullen face, or don't try to create, sympathy among the examiners. Smile, be look confident, and always be very respectful. That will sail you through. Now we have Dr. Giriraj Vibhute, our consultant from Retina Department from M. Joshi Eye Institute Group. So he will be covering, this is a very important thing. You have some OSCEs in retina, and retina is a very excellent subject for, getting a very tricky OSCEs. He's going to cover some representative OSCEs, how these questions can be framed and how to get ready. So over to you, Dr. Giriraj.
Yes, sir. Thank you so much. Is the screen visible, sir?
Yeah, you can make it full screen. Huh? It's okay, fine. It's visible very well.
Okay. Just a quick thought. Just now you said that don't use short forms. Life of a retina person will be very difficult if we do that. Otherwise, we'll be spending a whole day just expanding the short forms. Yeah, with that, I'll start with the first question. First OSCE, that will be one of the most commonly asked questions. Based on the fundus picture, identify the disease. You can see elevated lesion at the macula, usually seen in a young male patient in his 30s. Usually there will be history of steroid abuse, and there might be some sleep disturbance, obstructive sleep apnea, etc. Based on the fundus picture itself, it is a common diagnosis of central serous chorioretinopathy. You can see the elevated lesion at the macula. And identify the investigation modality is the next question. Of course, it is the fundus fluorescein angiography. When do we use this? When a patient of CSC comes, the first thing which you do is optical coherence tomography. So after that, you can observe the patient for treatment part. Usually because this is a self-resolving condition. If it doesn't resolve, then we come to the fundus fluorescein angiography, based on which is the most common pattern in this investigation, that is ink blot pattern. But the pattern which we are seeing in this picture is smokestack appearance. So in the fourth image, we can see the smokestack appearance. the fluorescein dye going up. Which disease spectrum this is part of? So CSC is a part of pachychoroid spectrum. Yeah, that is one of the important questions. So what do you do for this patient? Usually it is a self-resolving condition. Then if it is a fovea involving condition, you might think of micropulse laser, subthreshold laser, or photodynamic therapy. If it is away from the fovea, you might consider focal laser, which is a mild light burns. So yes. Yeah. So this is the answers. Okay, coming to the next question. Identify the procedure. As you can see, there is retinal detachment, there is a hole, there is a gas bubble inside the eye. So it is pneumatic retinopexy. What are the common indications, contraindications, and what is the maneuver followed? So this is an important trial which compared pneumatic retinopexy versus vitrectomy pivot trial. So this says the inclusion criteria will be all breaks in detached retina which lie above 8 and 4 o'clock meridian. So superior breaks are amenable to pneumatic retinopexy. Inferior breaks, they come into the exclusion criteria. Significant media opacity, associated proliferative vitreoretinopathy, and a patient who is not able to position properly are another contraindications. What is the maneuver which is used in cases of macula on RDs if you have injected gas to prevent macula from detaching? That maneuver is called as steamroller maneuver. So you ask the patient to lie down prone first to support the macula, and from there you ask the patient to turn his head in a clockwise manner so that the gas pushes the SRF away from the macula towards the brain. So that is steamroller maneuver. Coming to the next question, that is a 60-year-old patient with history of uncontrolled diabetes mellitus. Identify the condition. Again, this is one of the most common conditions which we keep seeing in our OPD, that is proliferative diabetic retinopathy with fibrovascular proliferation with a tractional retinal detachment. So the question is identify what the condition, what are the indications for surgery. So some indications are non-resolving vitreous hemorrhage, tractional retinal detachment, combined retinal detachment, then recalcitrant macular edema and traction involving the macula, epiretinal membrane with a foveal traction. These are some of the indications for surgery in case of PDR. Then what is crunch syndrome? It is one of the famous Viva questions. So that is when you give anti-VEGF in these patients, the fibrovascular proliferation can contract and increase into the tractional retinal detachment if it is always there, or it can lead to tractional retinal detachment. So that is crunch syndrome or anti-VEGF crunch syndrome. That is what it is called. So another famous question. Based on this OCT, they might ask you to describe the OCT. I guess there is a separate class on a description of images and charts. So you have to tell about which eye it is, how about the media, then about the vitreoretinal retinal interface. Then under the subretinal, under the retinal tissue, you can see a hyperreflective lesion, that is SHRM, we call it as subretinal hyperreflective lesion, that is CNVM. Again, age-related macular degeneration, wet form. The condition is CNVM. Most commonly used treatment modality is anti-VEGF injection. They might ask you what are the common regimens used. It can be either PRN regimen or treat and extend regimen. So what is the OCT-based classification of these condition? That is type 1, type 2, and type 3. Type 1 is sub-RP, type 2 is subretinal, and type 3 is RAP, that is retinal angiomatosis proliferans. So this identify the imaging modality. As we know, again, this is a commonly asked question. So this is a B scan. You can see a lesion at the posterior pole of the eye, which is a mushroom-shaped lesion or a collar stud kind of lesion. So the question is investigation modality, that is B scan, diagnose the condition, typical condition. You have to look at the A scan readings also, which are given underneath. So the lesion shows, or the mass lesion shows, internal hollowing, that is acoustic hollowing, the classical sign of choroidal melanoma. So that is B scan, choroidal melanoma, collar stud appearance, low to medium internal reflectivity, and acoustic hollowing. Coming to next, to identify, this is again a 52-year-old diabetic. Identify the imaging modality and diagnose. So you can see multiple areas of fluorescein leakage. So these correspond to the microaneurysms which are leaking, and then there are peripheral NVEs. So NV is in a patient of diabetic retinopathy, that is suggestive of proliferative diabetic retinopathy. You can't see any cystoid macular edema based on this. So the treatment would be pan-retinal photocoagulation. If there is cystoid macular edema, you might want to give anti-VEGF also, followed by pan-retinal photocoagulation. Then what are some indications for FFA, doing FFA in this condition? When do you want to do? You normally don't go ahead and do FFA in all the PDR cases. So some indications are when you are not sure whether there is NVE or not, to confirm that you can do FFA, or to confirm macular ischemia. What is targeted laser therapy is you do ultra wide field fundus fluorescein angiography. Based on that, you can see the non-perfusion areas and you can laser particularly to those areas. That is targeted laser therapy. So coming to some of the spotters, this might be kept as a spotter. This is the silicone oil, again common. Identify the condition. What are the types? It means the viscosity of silicone oil ranges from 1000 centistokes to 5000 centistokes. Commonly used is 1000 and 1500. In recurrent cases and in whom you want very long-term tamponade or you don't plan on removing the silicone oil, in such cases we use 5000 centistokes oil. So what are its uses? It is a tamponade agent in complex vitreoretinal surgeries. So if they ask you when would you use silicone oil over the gas, the expected answer is when you want long-term tamponade. Then you come to the answers like inferior breaks, or when you want another uses of silicone oil are when you want it for optical purpose. Like patient is one-eyed and if you put gas, the patient will not be able to see through that eye for 3 to 4 weeks if you are using gas. Then silicone oil is used. Another indication is you put silicone oil in cases of endophthalmitis after vitrectomy. It is known to have antibacterial properties. So that is another use. What are some problems associated with it? It can cause cataract. Then in aphakics, it can cause band-shaped keratopathy. And it obviously it can cause increased intraocular pressure, either due to the shear mechanical effect or due to the emulsified oil. Then iritis or anterior dislocation or subretinal migration of the oil. Silicone oil induced membrane proliferation can also occur. Rarely, migration of silicone oil along the optic nerve has also been reported. So next question is, what is this? As just now we discussed silicone oil. So this is its counterpart. This is the C3F8 gas, which is a relatively longer acting gas. So I have not given any marks to identify because the name is written there only. What are its uses again? So what is its non-expansile concentration and what are its contraindication? So it is used in cases where the patient can position properly when when the breaks are superior and a limited number of breaks. Then its another use is you use it for pneumatic retinopexy or pneumatic displacement of subretinal hemorrhage. What is the non-expansile concentration? It ranges from 12 to 18%. Commonly used is around 15%. What are the contraindications for this is if you have to restrict air travel, because as you go to high altitude, the gas can expand and lead to sudden increase in intraocular pressure and may cause pain and central retinal artery occlusion also. The nitrous oxide used in general anesthesia, you have to ask the anesthetist to stop the GA a little earlier before injecting the gas. Otherwise, it can mix up with the gas and expand. So that is about the C3F8 gas. This is again another commonly seen condition. Identify the condition, identify the appearance, what are its types, and management. Of course, based on the fundus image itself, it is a clinical diagnosis of central retinal vein occlusion. The typical appearance is called as tomato splash appearance. Usually the patient will be a hypertensive, or this is the first time the patient comes to us with diminution of vision and we diagnose the patient to have hypertension. When we check the BP, it could be in 180 by 100 or 200 by 100 like that. So types are, it can be either ischemic or non-ischemic. The differences they might ask you in the exams. You have to read it up. Then what is the management? In these cases, you manage based on, you first do the optical coherence tomography, whether there is macular edema or not. If there is macular edema, you can give anti-VEGF or steroid injection. If there is no macular edema, or if you can observe. If there is neovascularization, then you can consider laser therapy. All this is in addition to managing the underlying systemic condition. You have to refer the patient to physician for systemic evaluation and treatment for the associated systemic conditions. So yes, a 35-year-old male presented with sudden diminution of vision in his left eye while he was gymming. So this is the typical presentation of Valsalva retinopathy. The condition is subhyaloid hemorrhage involving the macula. That is the identification part. What are the causes for this? One of the causes can be Valsalva retinopathy, then hypertension leading to ruptured retinal artery macroaneurysm or trauma. These can be some of the causes. How do you manage this condition? This is YAG hyaloidotomy will be your first choice. If it fails, then you might resort to vitrectomy. Coming to next condition, a 42-year-old male with both eyes diminution of vision. Patient is on heart therapy since last 2 months. His CD4 counts are 42 cells per 42. Then what is the diagnosis? This is the typical presentation of CMV retinitis. So the appearance typically is called as pizza pie appearance. And the next question which will come will be asked is, how will you manage this patient? So the first thing, if the patient is not on heart therapy, you have to refer the patient to be started on heart therapy. The increase in CD4 count helps in these patients, and you can start the oral valganciclovir or IV ganciclovir also. Then identify the imaging modality and diagnose the condition. This is the classical picture of a classic CNVM. What is the cause of hypofluorescence in this patient? This can be a blocked fluorescence. The black areas which you can see above the classic lacy pattern of CNVM, that would be blocked fluorescence, probably due to a subretinal hemorrhage. What are the FFA classification? It can be either a classic CNVM or a occult CNVM. What is the treatment? As we know, it is anti-VEGF injections. Then next condition, earlier we saw CRVO, then again this is the superiotemporal branch retinal vein occlusion with macular edema clinically. So what are the risk factors commonly associated with this condition? As we discussed, hypertension, smoking, or elevated cholesterol levels, hyperlipidemia, these can be some of the conditions associated with this. And how will you manage the patient? Again, you will do OCT. If there is macular edema, you can give anti-VEGF or steroids and send the patient for systemic management. If the only indication for laser in this patient is if you suspect neovascularization. Coming to the next condition, we saw in the previous condition that was pre-retinal hemorrhage or subhyaloid hemorrhage. Here in this image, you are seeing something which is a subretinal hemorrhage. How do you differentiate between those two? You are seeing a vessel which is going over the hemorrhage area. So when you see the vessel going over it, it means that the blood is behind the retina. That is subretinal hemorrhage. So identify the condition is it is subretinal hemorrhage involving the macula. What are some of the common causes for this condition? The most common condition is wet AMD, that is CNVM, followed by PCV. Then some other conditions can be again trauma or a ruptured RAM or a Valsalva retinopathy again. How will you manage this condition? The primary mode of management, if it is involving the macula, is pneumatic displacement. You inject the gas inside the eye and ask the patient to maintain prone positioning so that this blood will be displaced away from the macula. So, and in case it is a massive hemorrhage, then the next line of management would be vitrectomy and subretinal injection of tissue plasminogen activator. Nowadays, we inject cocktail injection, that is tissue plasminogen activator with anti-VEGF and balanced salt solution and subretinal air also. So that is called as cocktail injection. Then a 49-year-old male patient, he is diagnosed to have hypertension since last 4 years. You see this kind of fundus picture. What would be your differential diagnosis? So just because he's hypertensive, you shouldn't rule out that he might have other conditions also. So this image I have put because many a times the patient will not know that he is also having a diabetes at the age of 49. There might be other kinds of anemia or any blood dyscrasias. So in such patient, you should keep all these things in mind. You can send the patient for further evaluation, and based on the pathology, you can go ahead. So systemic evaluation will include hypertension treatment, blood sugar level, CBC with peripheral smear, and a carotid Doppler to rule out ocular ischemia. OCT to look for macular edema, and you can treat accordingly. This can be again a spotter or a table viva question. So this is perfluorocarbon liquid. The most commonly used form of PFCl is perfluorooctane. That is what is PFO is what we call it as. Some complications associated with PFCl use is might be asked, and use of PFCl. When do you use it? So PFCl is used to flatten the retina to unfold a giant retinal tear which is folded on itself. Sometimes you inject PFCl to prevent any vascular ooze which can happen during a proliferative diabetic retinopathy vitrectomy case. Then PFCl can provide, can help you as a third hand when you are doing peripheral vitrectomy and you don't want the retina to flutter. So PFCl holds the posterior retina in place so that you can go ahead with your anterior surgery. Some disadvantage, most common complication is that retained PFCl. It is a colorless transparent fluid. Many a times you will not realize that you have not removed the PFCl completely, and it might, if retained, it might migrate into the subretinal space or subfoveal PFCl, leading to distortion of vision, and it needs to be removed if it is into the subfoveal space. How will you remove it? With the help of a 41 gauge subretinal aspiration cannula. It cannot be used for long-term tamponade if it is kept. Medium-term tamponade for PFCl has been described, but if kept for longer term, it can cause retinal necrosis due to mechanical compression of the inferior retina. So this is just a representative image. The questions can go to any anti-VEGFs. What are the types of anti-VEGF which are used in retina practice? So this is ranibizumab. Dosage is the most commonly asked question. Ranibizumab is 0.5 mg. What is the dose of aflibercept? What are the other dosage? Then what is the newer anti-VEGFs like brolucizumab and faricimab? It's faricimab, not faricizumab. Most commonly, I have seen the PGs doing this mistake. It's faricimab. Mention two conditions where they are contraindicated. The consensus is if a recent history of stroke or ischemic heart disease is there within last 6 months, we don't give anti-VEGF injections. And in pregnancy, in all the trimesters, it is relatively riskier, but most risky in the first trimester. Then this is again one of the conditions which we see commonly and operate commonly. This is a full thickness macular hole. What is the clinical test for diagnosis is Watsky-Allen slit beam test, where you shine a light and the patient will see a cut inside the beam. So that is Watsky-Allen slit beam test. Then what is the most common treatment for this is pars plana vitrectomy with internal limiting membrane peeling followed by tamponade and prone positioning. There are various techniques which are described for macular holes, but this is the most common technique. And yeah, coming to the next, what identify the investigation modality and identify the pathology. In this, you can concentrate on the hypersenescent or the hyperfluorescent whitish structures which are indicated by the arrow. Those are polyps. The investigation of choice in this condition is ICGA, and the condition is polypoidal choroidal vasculopathy. Then the anti-VEGF of choice in this condition is a longer acting anti-VEGF are preferred in this. So you, rather than going with ranibizumab, we choose either aflibercept or brolucizumab in these conditions. So yeah, what is this is again seen in patient who was operated for retinal detachment long back. Patient was lost to follow-up, and then he is coming to us after maybe 1 year or 2 years. And this is seen. What is the collection in the anterior chamber is called? It is inverse hypopyon or hyperoleon. What is the name of the PI done in such conditions? You can see the inferior PI done in these conditions, that is called as Andos PI. How does this work? Because silicone oil is lighter than aqueous, it floats up and it can cause pupillary block. So the inferior PI allows for the aqueous to flow to AC and behind. It allows for free communication, preventing the elevation of IOP. Fine. So that is about the Andos PI. Then this is the last and bonus question. Identify this image and what are its indications and which quadrant of the eye it is placed in. So this is a bonus question. This is not a very commonly done procedure, but commonly discussed in retinal conferences nowadays. This is the macular buckle. This is the NPB type of macular buckle, which is self-sustaining. In the image, you can see it comes with a loading device. It is inserted into the superotemporal quadrant and it goes at the macula, and it is just sutured at these suturing holes. So the most common indication for this would be myopic tractional maculopathy. So because there is posterior staphyloma, your ILM peeling will not work because there is no support from the back. So you, rather than pushing the retina towards the sclera, you push the sclera towards the retina by a macular buckle. So that was the bonus and last question. With that, I'll stop here. Thank you.
Thank you, Dr. Giriraj. I think that will probably give us an idea about probably what all can be asked in the retina. I think all the students had some idea about what to expect, how to answer. I think we have another our retina consultant, Dr. Apurva, joining us. Dr. Apurva, are you there? So till she joins, some
Yes,
of
sir, I'm
the
here. You
okay,
can, till I join, yeah, please go on.
okay.
Yeah.
Thank you so much for joining. So basically, I was just trying to tell you uh, a chart, a perimetry chart is something that you have to expect. Some eye drops on the table is the something to expect. As I told you, pick up an eye drop and they will ask you to tell something about it, right? So always choose timolol, pilocarpine, or if they give you an eye drop, then you have actually no options. So where you can really discuss, always create a format. I know you can talk a lot about timolol, but only if you have a format so that you don't really stutter, you don't stop, and you don't miss anything. Always tell this is an eye drop containing, always tell the salt, timolol maleate. Always tell the percentage, 0.5%. Sometimes timolol can be a something like an what Timolet OD or glucotim LA, which is a prolonged release or a sustained release, one which works 24 hours a day. You can say it's a sustained release preparation or a slow release preparation of timolol maleate, 0.5%. Always tell what is its pharmacological name, like a non-selective beta blocker or a non-selective beta adrenergic antagonist. You have to say the pharmacological name in the beginning. Then please tell the clinical application. It is used in the medical management of glaucoma to reduce the intraocular pressure. If it is pilocarpine hydrochloride, you say it is used in the treatment to medical management of glaucoma to reduce the intraocular pressure. It's also used to constrict the pupil as a miotic, right? So you can change it accordingly. Then you say, what is its mechanism of action? So it reduces the intraocular pressure by decreasing the aqueous production by acting on the ciliary epithelium. So this is how, or you can say as a pilocarpine, it constricts the pupil by acting on the sphincter pupillae. Since it's a parasympathomimetic, it acts on the ciliary muscle, puts the ciliary muscle into contraction, puts the eye into a state of accommodation, and also pulls the the scleral spur, changing the configuration of the trabecular meshwork, facilitating the outflow of aqueous. Right? So you can probably plan all these. There is so much to talk about these drugs. Then tell the duration of action and the dosing. Duration, it acts for 6 to 8 hours, so 3 times a day. It acts for 12 hours, so it's twice a day. Since a sustained preparation, it can be used once a day. Then you tell its side effects, tell its contraindications. They are different. For example, pilocarpine, the side effects are in relation to the pupillary constriction and also because of the ciliary spasm. For pupillary constriction, the side effects of pilocarpine are it decreases the scotopic vision because the pupil doesn't dilate in dark. So patient has a subnormal vision in dark because of pupil not dilating in dark. At the same time, the patient has any media opacity in the pupillary axis, like a central corneal opacity or a posterior subcapsular cataract, then the pupillary constriction can reduce the vision drastically. right? At the same time, ciliary spasm or ciliary muscle contraction can give the patient a broache or a headache or a referred pain, especially in young people. It can also cause meiotic cysts. It can also put the eye into a state of, pseudomyopia. It can probably cause the ciliary contraction, puts the eye into a state of accommodation, so causes myopic shift. So these are some of the side effects. But contraindications are totally different. For pilocarpine, contraindications, any glaucoma associated with inflammation, like postoperative glaucoma, neovascular glaucoma, uveitic glaucoma, and it is highly contraindicated in aqueous misdirection syndrome or malignant glaucoma. So you plan the whole thing and pick up the pilocarpine, you will hit the ball out of the park. Okay. Now we have Dr. Apurva Ayachit. She's known for simplifying the charts, especially the retina chart. So this is a chart buster session. She will probably pick up some 10 most important, most commonly found items on the Viva table. And these are the torture equipments for people in the Viva. And she's going to simplify it so that you can how to actually explain. See, you know what it is, but you don't know what words to use, how to explain, how to simplify it. So over to you, Dr. Apurva. You can share your screen now.
Thank you, sir. Okay. So let me get to it without further ado. So let us bust some charts which are commonly kept. Instead of charts, you did say table Viva, sir. So first, like in charts, many people are good at, but I'll be coming to them subsequently. This is one of the things that you'll find on the table. So once you see this, I think it is very simple. This is brilliant blue-green solution. Everything is written in bold. If even there is a vial there, you can pick it up and you can read the concentration, no problem. Nobody will black it out for you. 0.05%. Now this is different from trypan blue. So trypan blue is for capsule staining in cataract surgery. Brilliant blue-green solution is used for staining the internal limiting membrane in macular surgery. Macular surgery can be either ERM peeling with ILM peeling or for macular hole surgery where you're doing a ILM peel, inverse ILM peel, all that, those things you know. So brilliant blue-green solution is injected about 0.5 ml and it is kept for a contact time of 10 to 15 seconds. In order to improve the staining, some things are done like switching off the infusion for a few seconds so that there is no dilution of the dye by the infusion fluid. Some people use air infusion, put the dye and then switch back to fluid infusion to reduce the dilution of the dye. So these are the methods of increasing the contact time with the dye. And then once it stains the ILM, it is easy to peel. So they can ask you which instruments are used to peel the ILM. It can go into that direction. You can say ILM forceps, end gripping forceps, diamond dusted forceps, so many things are different. Surgeons use different forceps. And dye toxicity can happen, which can be augmented with prolonged phototoxicity also because of the endoilluminator. So this is everything about brilliant blue-green solution. Some other dyes that are used for macular surgery are infracyanin green and indocyanin green. Indocyanin green is toxic to the photoreceptors, so it is not used, especially not in Asia or definitely not in India. It's used more in the Western population by Western retinal surgeons. And yeah, that's about it. This is BBG. Then what is negative staining? When you stain in cases of epiretinal membrane, the epiretinal membrane doesn't get stained. The surrounding ILM gets stained. So what is not stained is the ERM. So you can peel the ERM because it is not stained. So that is negative staining. Once you peel the ERM, then you re-inject the dye, that will stain the ILM. So I think this is most of the things that you can talk about in OcuBlue or brilliant blue-green solution. And don't the vial will have the concentration written on it. So this is a PRP lens. This is a Mainster lens. there is something called static field of vision and dynamic field of vision. So this is used for slit lamp delivery of laser and mainly used for panretinal photocoagulation or sectoral photocoagulation, wherein you deliver spots of a certain size. Depending on the indication, you have, for example, for PDR, you do panretinal photocoagulation where you use single spot or multi-spot laser, where the laser burns are one burn width apart. So now they will ask you, how do you titrate the power? What is the power? They'll say. But always remember, there is no like a set power which you use for PRP. It is a range, and it is what gives a grade 3 burn. For every patient, it is different. In a clear lens patient, even for like 250 milliwatt or 200 milliwatt is enough. Whereas in a patient with even grade 1 nuclear sclerosis or higher, then your power will increase. So the interval, especially in a if you're doing a continuous delivery mode, then the interval between two laser spots is also between a range of 100 millisecond to 300 millisecond, based on the convenience and comfort of the person who's doing the laser. So you should know the range of the duration of the laser spot and the interval between two laser spots. Then the pattern laser means where there are multi-spot lasers, it reduces the time taken for doing the laser. Nowadays, most people do multi-spot laser, wherein multiple spots are given in one press of the foot pedal of the laser. So you can use 5x5 grid or 7x7 grid, depending on what is available. Then which are the lasers available? 532 nanometer green, 577 nanometer yellow. So these are the commonly used lasers for slit lamp delivery of panretinal photocoagulation. And this is the lens used for PRP, where this is a contact lens where you place it with a coupling agent and lignocaine jelly for anesthetic. You place it on the cornea and you focus the laser beam onto the retina. And what is the pattern of the PRP, where till where you should do, they'll ask. How many sittings they may ask. So 2 to 3 sittings. Start with inferior retina, because if the PDR patient bleeds, then the VH comes inferiorly and you will not be able to laser the inferior retina later. So that's why we always try to finish the inferior retina, then the temporal retina and the superior retina. You can come as close as 2 disc diameters temporal to the macula and 1 disc diameter nasal to the disc, and above and below the just above and just below the superotemporal and inferotemporal arcades respectively. So these are all burns are almost 2000 to 3000 burns, one burn width apart, are placed for a case of PRP. What are indications of PRP? What is the how does PRP act? The mechanism of action of PRP, why it is done? Those things you have to read up. So they will ask magnification factor. So some lenses you can know the magnification factor. Laser spot magnification is a 0.59x. I am also forgetting. So please brush up. You will find tables for lenses. So insider info is that, even see, like I said, I also don't remember exactly. So if you tell near the correct answer also, it's okay, because every lens is different. Some have 0.47, some have 0.59. So it's difficult to remember, but try to memorize some 2 to 3 lenses. Next is this one. I think Dr. Giriraj discussed ranibizumab. So aflibercept injection, which VEGF isoforms it binds, VEGF A, VEGF B, PDGF, those things, and why it's called VEGF trap. What is a decoy receptor? It's a decoy VEGF receptor. Then what is the dose? So 2 milligram in 0.05 ml is the dose. It is the agent of choice for PCV. And for refractory macular edema, for refractory neovascular AMD, it can be used. Refractory to treatment with bevacizumab or ranibizumab. Then some other anti-VEGF injections, I think Dr. Giriraj already told. So these are what is the distance of injection from the limbus for aphakic patient, pseudophakic, phakic patient. Then what syringe is used? Tuberculin syringe is what we use, or you alternatively a 1 cc syringe with 30 gauge needle can also be used. And apart from that, then we have this. Now coming to some charts, this is a B scan. So usually they should always provide an A scan as well. So here is a hyperechogenic linear membranous echo that is seen, which has a connection to the disc, which is attached to the disc, and it is funnel shaped. We would like to look at the A scan also. Now, if there is a high A scan spike corresponding to this hyperechogenic membrane and the reflectivity is equal to the sclera, then it is more likely to be a retinal detachment. So this can be differentiated from PVD by the fact that PVD has lower echogenicity and it is freely mobile. Once the PVD is complete, it is no longer attached to the disc. There will be after movement. So with movement of the eye, once the movement stops also, it will have a movement. So it is called a after movement of the PVD, the posterior vitreous detachment. Also, when you reduce the gain, then the retinal detachment persists even on reduction of the gain, whereas PVD linear echogenicity disappears with reduction of the gain. Then you have this. So this is something which is commonly done, a scleral buckle. So buckle elements are basically having a width depending on the buckle element. Is it 277 or 279? So it has a groove, as you can see, and this groove is for the 240 encerclage belt. So 277 buckle element is 7 mm wide and a 279 buckle element is 9 mm wide. So if the break is more posterior, then you tend to use a broader buckle. Buckles, excuse me. So this is, close the door, please. Yeah, so this is the groove for the 240 belt. Can you mute that, please, sir? Yeah. So this is the groove for the encircling band, the 240 band, and it goes all around the globe, whereas the buccal element buttresses only the retinal break. So this is about buckles. So these are vitrectomy cutters. So different cutters are there, and the higher the number, lower the gauge. That is the diameter of the sclerotomy opening. So if it is an Alcon cutter, the 23 gauge is usually orange, 25 gauge is usually blue, and 27 gauge is purple. However, this color coding may not be there if it is another manufacturer's cutter. So you can always guess the gauge of the cutter. Please make sure you go to the OT and you can see that the 23 gauge is the shortest, 27 gauge is the longest and the thinnest. And they'll ask about the port location. This is all little advanced viva. Port is very close to the bevel. And what are the cut rates used? 10,000 cut rate. What is the vacuum used in vitrectomy? For core vitrectomy, it is higher vacuum, 650 mm Hg, whereas for peripheral vitrectomy, the vacuum is slightly lower. That is, you can use a range from 400 to 450 mm Hg. Then you have smaller gauge vitrectomies are safer. There'll be some sphere of influence and all, but I don't want to burden you with that because I don't think they will ask residents about such advanced things. Little bit of fluidics of cutters, if you know, it's good. So this is a laser probe. You have a linear laser probe and a curved laser probe. This curved laser probe is what helps to protect the lens. Basically, when it is curved, then the concavity is towards the lens and the cornea. It's like this inside the eye. Never keep it like this and operate, because then it will touch the lens above. So that's why you have a curved laser probe, which the concavity of which is towards the lens. So curved laser probes are to avoid lens touch, and you can go all the way up to the opposite periphery to laser. Again, laser pure point lasers are there. You can, again, it's a range of power. Okay, so it's not like you have a set power. Don't fall into that trap of what is the power used. You always say the power that is enough to get a grade 3 reaction. So know the grades of laser burns. Grade 3 is a yellowish burn, visible burn, and grade 4 is yellowish white, and grade 5 is chalky white. So you have the power as much as required for a grade 3 burn. So then they'll ask about interval and duration. Duration is not more than 100 to 150 millisecond. Whereas interval can be varied, means the interval between two laser burns. Okay, two consecutive laser burns. It can be anywhere from 100 millisecond to 200, 250 millisecond. This is a 5-0 ethi bond. It's a polyester suture, and it is used for sutured scleral buckles. So we saw 277, 279 scleral buckle elements. You use these sutures to anchor on either side of the scleral buckle to the sclera. So you take a curved path of the needle goes through partial thickness sclera, not too deep, otherwise it will cause a scleral perforation, and not too superficial, it will cause cheese wiring. So now you always place the suture or 1.5 to 2 mm on either side of the scleral buckle to achieve indentation. So next is triamcinolone acetonide. This is one of the most versatile pharmacologic agents. It is used for posterior subtenon injection, where it is used as 20 milligram per 0.5 ml. So the volume in the posterior subtenon triamcinolone acetonide is 0.5 ml. Whereas, I'm sorry, 0.5 ml, 20 mg of drug. Whereas in intravitreal dosage, it is 1 unit, 1 milligram. Okay, so 1 milligram, that is 4 units. And for intravitreal triamcinolone acetonide is also used, not only used for macular edema due to various causes, like say DME, recalcitrant DME, or a retinal vein occlusion causing macular edema, uveitic macular edema. It's not only used for that, but also used for posterior vitreous detachment. So the posterior vitreous phase detachment intraoperatively is assisted by triamcinolone acetonide, where the crystals stain the posterior vitreous and it helps in PVD induction. So these are the uses of TA. Then they'll have an OCT on the table, obviously. So this is one chart. I use this OCT to highlight that there are most of the findings that you can see involving all the steps of interpretation. The steps of interpretation of OCT is, first you look at the vitreous, then the vitreomacular interface, retinal architecture, the RPE, the choroid. So now if you see, let's look at the vitreomacular interface. Now there is a vitreomacular traction. This is a focal vitreomacular traction. This is less than 500 microns of attachment. That's why it's called a focal VMT. Why it is not adhesion and why it is traction is because it is causing a structural change of the macula. Okay, so this is why it is a VMT and not a VMA. So now coming to the foveal contour. The foveal contour is grossly lost. It is, the retina is elevated. So the foveal contour is lost. There's a large cystoid space at the fovea, coming to retinal architecture, large cystoid space at the fovea, along with hyperreflectivity intraretinally and subretinal fluid. Okay. And here also you have loss of architecture of the outer retinal layers, which is replaced by hyperreflective material. So then you have the RPE. If you trace the RPE like this, there is irregular elevation of the RPE. You can see especially on this side. Okay. And then you see the choroid. The choroid seems to be thickened subfoveally, although you're not expected to know so much about the choroid because it's always a relative thickness. Depends from patient to patient, according to ethnicity, relative to the rest of the choroid. Many things are there. So how do you know which eye OCT is this? If I had not given the picture on the left, I hope you can see my pointer. This is right eye OCT. This arrowhead, the arrowhead corresponds to the right hand portion of the OCT. Okay. So if the arrow is oriented like this with the arrowhead superiorly, then the right hand portion of the OCT is the superior macula. Here, the right side portion, the arrowhead is showing this way. This is the arrowhead. So the right hand portion is the nasal macula. You can see this is the nasal macula, temporal macula, superior, inferior. Arrowhead, right side portion of the OCT is the nasal macula. If you see, this is the RNFL. This is the RNFL. Always the papillomacular bundle is very thick. So the RNFL will be very thick on the side of the papillomacular bundle. So even if I don't give you this image, this you can say is on this side. So whichever side the papillomacular bundle is there is that side, that eye is OCT. Coming to the next chart, this is quite obviously a cherry red spot with the pallor of the macula. Pallor, global pallor is there of the retina. And you can see some cattle trucking here with these linear plaques also are there. So what you expect on the FFA? There is a delayed arm retinal time. Okay, so normal arm retinal time is around 10 to 12 seconds. Here it is highly prolonged. This is 1 minute. See, at 1 minute 20, I hope you can see, I don't know. Yeah, at 1 minute 21 seconds also, there is no filling of the retinal arteries. So delayed arm retina time is there. Slowly the retinal arteries are filling up. And here you can see more filling. And you can see delayed arterial filling time. The arterial filling time also takes around 14 seconds to 20 seconds. So the arterial filling time is highly delayed. Then there is delayed arteriovenous filling time also. So you should know the retinal, the phases of a fluorescein angiogram. You should know the concentration of fluorescein dye, sodium fluorescein. So we use usually 2 to 3 ml of 20% fluorescein dye. You should know the contraindications like known allergy to fluorescein, pregnancy, renal failure. These are also contraindications for FFA. Okay, so this is a case of CRAO. Then what are the indications of FFA in diabetic retinopathy? You should be very thorough. It should be at the tip of your tongue. Now, this is a typical fluorescein angiography of a central serous chorioretinopathy with a smokestack leak. This is the corresponding OCT. Now, let's see this also one by one. Foveal contour is, the vitreomacular interface looks okay. Means there is no hyperreflective vitreous attachment to the fovea or anywhere at the macula. So vitreomacular interface is okay. However, the foveal contour is not there, obviously. And there is a large amount of subretinal fluid, the small neurosensory dip, and a small PD. Okay. So this is highly suggestive of a central serous chorioretinopathy, and this is the FFA. So when you see an FFA, you should see whether the veins are filled. If the veins are not completely filled and they have a laminar flow, then it is a early AV phase, arteriovenous phase. If the veins are filled, then it can be early, mid, or late AV phase. Now, depending on what structures you can see on the FFA, you can say usually they keep, if they're keeping a case of diabetic retinopathy, if there are microaneurysms that are discrete, then it is usually early AV phase. Let me give you an example. Yeah. So this case, for example, you can see that the veins are completely filled. Okay. So it is not early AV phase because there's no laminar flow in the veins. It is filled already. So let's call it mid AV phase. Why I am confident about mid AV phase and not late AV phase is because in this angiogram, you can see these discrete aneurysms. If it is late AV phase, then the microaneurysms start leaking, which brings me to the point of why we have to interpret this finding in the early to mid AV phase, because in late AV phase, the microaneurysms start to leak and obscure the visualization of the foveal avascular zone. Now, actually, this is the foveal avascular zone. I mean, this is the fovea, guys. Okay, this one. I was showing this to show the phase of the angiogram, that the microaneurysms are not leaking yet. So now if you look at this foveal avascular zone, this is of course a macular non-perfusion area. I'll come to that. I'm using this example for telling you about the phases of the angiogram. So normal foveal avascular zone is 400 to 700 microns. However, if there is loss of the circularity of the FAZ or change in the shape of the FAZ, where it becomes either amoeboid or notched, for example, then it is ischemic maculopathy. Okay. See this, for example, these are non-perfusion areas that are seen and it is almost coming up to the macula. And the same non-perfusion is seen at the fovea also. So in this patient, if the vision is not correlating with the fundus finding, see this fundus looks very innocent, but the vision is only 2/60. That is because of ischemic maculopathy. So the BIVA will go towards what are the indications of FFA in diabetic retinopathy. Okay. And then this is one more FFA of a classic CNVM. Okay. Yeah, this is the typical cartwheel appearance, lacy hyperfluorescence of a classic CNVM. Classic CNVM always corresponds to a type 2 CNVM. Type 2 means subretinal in location. Let's go back to the first OCT that we saw. This is actually a type 1 CNVM, where because there is an irregular elevation of the RPE means the membrane is under the RPE, and whatever is above it is because of the activity. This is all suggestive of CNVM activity, whether intraretinal fluid, subretinal fluid, hyperreflective material, increase in the size of a serous PED, hemorrhage, exudation, all these are signs of active CNVM. So type 1 CNVM is under the RPE. Type 2 CNVM is between the retina and the RPE. And type 3 CNVM is intraretinal. I'm sure you all know this. I'm just telling you. Okay, now coming to this B scan. So this is a B scan, and you can see that there is a hyperechogenic structure in the ocular coats, and it is casting a back shadow. Okay, and here there is a PVD and possibly an RD also. It's hard to say if there is no A scan given. And you have to look for after movements also. However, this is a typical hyperechogenic finding, hyperechogenic structure casting a back shadow, and it is embedded in the coats. It is highly suggestive of an intraocular foreign body. They can also keep a B scan of choroidal osteoma, where there'll be a double disc sign. They can keep of melanoma, where there's collar stud appearance, kappa angle, and like a choroidal excavation, post-acoustic shadowing, choroidal excavation sign in a choroidal melanoma. They can also keep a B scan of cysticercus, where there is a hyperechogenic wall with a hypoechogenic cavity and a hyperreflective, hyperechogenic scolex. So cysticercus also they can have. Now, this is the last chart. Always, usually when there is an ERG kept, they usually keep the reference normal ERG for you. Okay, this is the 0.01 scotopic. This is 3.0 scotopic, and this is maximal cone rod response. That is 10.0 scotopic. Then you have 30 Hertz flicker and photopic. You see in this patient, the scotopic response with 0.01 stimulation is not, there is no B wave at all. Means the photoreceptors are not producing any wave. Then the dark adapted, scotopic is dark adapted. So dark adapted 3.0 also, there is no response of the photoreceptors, nor there is A wave, nor there is B wave. Even in the maximal response, there is no A wave or B wave. Coming to 30 hertz flicker, there is no flicker, means the cones are also not producing any response. And this is the photopic with white light. Here also the cones are not, you see the reference waves, you will see that there is no response. So this is most likely an advanced rod cone dystrophy, suggestive of advanced retinitis pigmentosa. So they may keep this multifocal ERG. Again, this is the reference MFERG with the central foveal peak. And if you see carefully in this case, there is pericentric amplitude, reduced amplitude. Okay. So whenever there is pericentral foveal loss of foveal perifoveal, I'm so sorry, loss of amplitude of the perifoveal responses, it is suggestive of hydroxychloroquine toxicity. So they may keep HCQ toxicity in MFERG. That's the only MFERG where, that's the only diagnosis that they usually ask in HCQ toxicity. What I can do is I can list out everything about each slide and I can post it on the groups. I can put even more charts if you're interested. If you have any charts in mind, please feel free to WhatsApp me. I will write 4 to 5 points about what to speak about them. And I hope that will help you break your head a lot less.
Thank you, Dr. Apurva. I think that's a quite an extensive and probably the most needed coverage of the retina chartbusters. I think you have busted a lot of myths and created the new ones. Okay, in the end, to wrap it up, so all the students who are watching this, your exams are a few days away. So be very confident. You're all going to make it. You have worked hard for 3 years and you have all cleared your theory exam. So practicals is just a small feat for you. So be very confident. This confidence will go a long way. So wear a smile, be confident, be nice, articulate well. Don't simply get into the anxiety mode or any some kind of a fearing the future, what will happen if I don't answer. Don't bother about that. Leave that moment. Just live in that moment. Don't go into the futuristic mode. Just be confident. And whatever you don't know, it's fine not to know. Most examiners will accept that they don't expect 100% of answers from the students. In fact, not knowing few things is also good. So you can probably find out what you know best. They will try to find out. And be very, very confident about it. Please rehearse the common things. Go through the simulation exercise. Just go through, mentally go through the exam again and again so that at that time when you really actually face it, it looks like a simple thing. And list all the cases that you can get. As I told you in the very beginning itself, the common cases that we get in the OPD, corneal ulcers, glaucomas, keratoconus, retinal conditions. So there are only few things that can, some entropion, ectropion. So the common conditions, just go through some, model case presentation. And is there a format for a case presentation? This is a very common, doubt. Like each institution have their own method. So if the examiners probably does not know our method, or if he's probably not okay with the method or the sequence that we present, it doesn't really matter. Case presentation is like a storytelling. You need to probably articulate, communicate the details about the case that you saw. And many a times you will be taking the case in a center where the patient may not speak the language that you know. There will be an interpreter, probably a non-medical interpreter, a staff or somebody who probably there can be a lot of miscommunication and you may not be able to see. They can also happen that you may be the first student to go into the case presentation. So you may not be given enough time. So examiners are hurrying it up. You get 2 cases in finish in 30 minutes, 40 minutes. So you may have any time to write down anything. So at the same time, you may be the last student who may get a chance after 3 hours of waiting. So be ready for all such eventualities. But nevertheless, examiners are usually kind. It's they're not one person's opinion. All the 4 will sit in the end. They will always put the marks with a pencil. That itself shows that nothing is final. They always sit in the end of the day and decide your answers. And there are some common mistakes which people don't tolerate. Obviously, if you don't really tell the vision. See, vision is the most important part in ophthalmology. So in each eye, right eye, left eye, please tell the unaided vision. Please tell the pinhole vision. Please tell the BCVA with the glasses or with correction how much the patient sees, the visual potential, and also tell what is the refraction that is accepted. What is the acceptance or what are the type of glasses or what is the refractive error of the patient approximately. So these 4 things go without fail, and always add the near vision. Even in a younger patient also, please specify the near vision. So that is most important. This is a very comprehensive vision assessment, and these are the 4 things that you need to tell. Whether you tell a head posture, whether you tell an ocular symmetry first, whether you talk about ptosis, then the eye, whether you tell IOP in the middle of the examination or the end of the examination, it doesn't really matter if you make sense from your articulation. But tell the provisional diagnosis. Never make a definite diagnosis. Always use words like suggestive of. Always say most probably, or I would like to give a differential diagnosis. Don't be very too sure about the diagnosis, which doesn't go, well with the impression. Always say if you got a proptosis, you've got a cavernous hemangioma, don't say cavernous hemangioma because nobody can be sure clinically. You say it is an orbital SOL, space occupying lesion, most likely to be cavernous hemangioma. Suggestive of this field defect. Don't say glaucoma. This is suggestive of a glaucomatous defect. I would like to look at the optic disc. Okay, so this is the way you kind of connect the dots and get the impression. Okay, so be happy, be confident. Go for it. The last few days, give your best shot, and we want all of you to be very victorious in the end and have a great exam. All the best for your future. I thank all the participants, Dr. Giriraj, Dr. Apurva, Dr. Aniket, for really supplied a lot of information to our students, and also the Microvision for getting the platform ready for us, who are always encouraging for these PG programs. So all the best to all of you, and see you soon with your flying colors with your postgraduate degree very soon. All the best.
Thank you very much, sir, and wish everyone all the best for their exams.
Thank you, sir. Thank you so much, sir.
Thank you. Good night.
Good night, sir. Good night, sir. Thank you. Thank you.